So good afternoon, everybody. Welcome to this session on expanding the boundaries of oxygenated perfusion, specifically about the Asia-Pacific region. Thank you to the ILTS committee and to Bridge to Life for this opportunity. It's my pleasure to introduce, can you see my slides? Are my slides visible? Okay. So it's my pleasure to introduce this topic and kick off, hopefully, what's going to be an interesting and engaging discussion which is relevant to this particular part of the world. These are my current appointments. I do not have any competing financial interests in this. So when we talk about the Asia-Pacific region, we are actually talking about quite a big swath of land here. So it's about 22% of the land mass of the world. It's more than half the population. It's about 2/3 of the liver disease burden of the world. And interestingly, the liver transplant journey here has been different. It has evolved predominantly around a living donor base, but of course, DDLT is picking up in several parts of this region as well. When we look at India, the picture is relatively similar. There actually has been quite a significant change in the donation rates in the last 12 years. In 2011, when I left Canada to come back to India, we had 11 donations in my state. Last year, we had 180. So the donation rates have gone up by 11-fold in about 13 years. So although these are small numbers, but it's a beginning. And actually 1 in 4 transplants performed currently in India comes from a deceased donor. There is a very big geographic variation in India when it comes to deceased donation. The north of the country still has a very small amount of deceased donation, but the south and the west have significant amounts of deceased donation. However, despite all these organs being donated, and these are DBD donors, there is still a lot of wastage. As discussed, in the state where I work, 178 donations happened last year, but 155 livers were usable. So almost 1 in 4 livers, even from this relatively small number, is still being wasted. Of the organs that we actually accept, there are still organs that move to primary non-function. So clearly there is a need for an assessment of viability before we can actually transplant organs. So why machine perfusion? Because of course there is a shortage of organs. We need to use every organ that we get. We are getting more marginal donors, older donors, etc. And the primary problem in our part of the world is poor donor management. So wherein you see a lot of data on DCD for hope, which is predominantly what it's used for. In most of the data that comes out of India is using this organ for reviving organs from donors who have not been managed well in ICUs. And of course, there are logistical and transport challenges. As donation increases into tier 2 and tier 3 cities, there are logistical challenges of transport by road, moving organs from one place to another, and that often adds to the cold ischemia time and the allograft dysfunction. So why machine perfusion? Of course, you have machine perfusion will allow organs to recover. There is a very high incidence of baseline metabolic liver disease. So in Bangalore, where I currently work, almost 80% of the urban population has metabolic liver disease of some form. There are time logistics, traveling teams, of course, and they can select organs that are transplantable. We also have had to work with slightly different service models because not everybody can afford the upfront cost of a machine. So the machine as a service model is something that is being utilized in India and perhaps in other places in Asia as well, where we call out for a machine and a technician when we need to use it. Of course, the equipment for a VitaSmart is much more robust. It's easy to deploy, and of course, and the big gap right now is the assessment of viability, which hopefully we'll talk about a little bit more. So my final slide basically on the Indian data is over the last 2 years, we've used this for 77 cases. For most cases, it's been used for moderate to severe steatosis. Some of the cases have been used for logistical use. Controlled DCDs are in a very, very small proportion of India. It's still not really picked up across India and the Southeast Asian region. But as you can see here, the non-function rates are still relatively high, even in this limited cohort of patients. So clearly there's much to do, much to learn, but the use cases that we will consider perhaps in this region will be different from what you've heard so far. So it's my pleasure to introduce the panel, Dr. Andre Schlegel and Dr. Rebecca Mateos, who are going to take us through what's new and what's current in VitaSmart. Thank you.
Okay, good afternoon, everyone. Thank you, Sonal, and thanks to the organizers for having me. It's amazing to see so many friends and colleagues, and it's a pleasure to be here. I'm Andrea Schlegel, I'm a transplant surgeon, and I have also my own research group, and I'm working in Cleveland at the moment. My disclosure, we use Organox clinically based on the FDA approval at the moment, and of course I'm collaborating with different systems. Okay. Hope. Yeah, well, my first Hope case was in January 2012 when we did the first DCD human liver transplant with hypothermic perfusion, and we used at that time an ECMO device from liver assist, organ assist, basically at that time. So a lot has happened in the last 14, 15 years in research, in clinic, and I'm going to try to summarize that a little bit and to focus also a little bit what we expect and what we want, showing clinical outcomes, how it's utilized, what's the adoption, what are challenges, and of course, as Sonal already said, we need viability assessment for sure, not only during NMP, but also in the cold. This is a summary. In 2012, there were basically Spain with a little bit of NRP clinically, then there was James Guerrera with HMP with no additional oxygenation, and the first DBD case in 2004, and we in Switzerland with Philip Dukowski did the first DCD transplant. And that is an old paper already. You can see a lot of countries are missing. In 2025, colleagues in Russia also have done Hope and many others too. So what is the expectation? I think across all countries we have the same dreams. We want to come in the morning, we want to know, will this liver work? And will it lead to no challenges in my very sick recipient with many other problems? And is it also effective and cost neutral or efficient? So my administrator is not bothering me later after 3 months with a high hospital bill. But to unlock this enormous potential, Doris Zegev just spoke earlier about the donor pool, we need the viability assessment for sure. Before going into the Hope, I want to highlight a challenge. My postdoc, Sangita, did an amazing job analyzing how we report outcomes with machine perfusion techniques. And looking just at the square with the biliary complication, you see that we are very poorly and not uniform in our reporting. Not only that we do not report the standard anastomotic, non-anastomotic strictures, we have also a very poor definition and no consensus here. Here's a little bit short summary on Hope. Hope is basically cold, it's simple, you can leave it alone in the corner, so it's not so spectacular, it's not a blood-based perfusate, but it's very effective and it protects mitochondria. The initial perfusion was at least 2 hours recommended, but we have now more than 15, 20 hours reported. It's 8 to 10, 12 degrees. We have a lot of oxygen, and it's effective after cold storage, which is in contrast to other perfusion techniques as we see in some mechanistical studies. And you see the first Hope DCD liver, you see an example from India, typical, very steatotic. You see a split on the right side. This is an example from my lab, and Rebecca will talk about that a little bit later. So the source of evidence supporting this technique is ever growing. You see the overall perfusion technique literature on the left side. Every year we have more, and you see 25, we have already more than half of what was reported and published in 24. So we have a growing body of randomized trials with Hope, so now 7 and 2 more are awaited. We have large clinical studies which are controlled. We have meta-analysis and network meta-analysis where you can now also compare a little bit Hope to other techniques and not only to cold storage. And we have also a lot of mechanistical studies which are growing too. Now, looking at the randomized trials, most, of course, came from Europe. You know that 21 was the first study from the Netherlands in DCD livers, and then we have some from Italy, multi-center. We have a study from Poland, and the US study published, and 2 more are coming probably this year. Now, everyone knows this study. I'm not going to go too much into detail, but showing that you have a significant reduction in biliary complications is very important, and not only a reduction in EAD and interventions, but mainly the cost contributors are relevant. And it's interesting because this DCD randomized trial on the left has also paralleled the study from Turin. Damiano Padrono and the team did that job and showed that in extended DBD livers you have a similar effect. So less biliary complications, you have less interventions, and also a better graft survival. And the same happened if you look at the cohort in Switzerland. This is one of our work published in 2024. You see how it evolved over time. And if we think back, and I remember one of the meetings in 2013, we presented the first 5 human cases. It was ridiculous. And now we are here today, and many countries have started it, and we are more now in the third, row of that saying, where many people have accepted it, and it's very evident that HOPE is a good technique for centers to start machine perfusion and also risky livers and improve outcome. This is the largest evidence outside randomized trials for now. It's 1,200 transplants from Europe with the hypothermic oxygenated perfusion, and from Italy and Netherlands and also Switzerland, there's a lot of livers with very high risk. You can see that it's an excerpt of the DCD cohort with more than 400. And interesting is that HOPE in these cases, in this cohort, achieved the same outcome for DCDs and DBDs, but also the same outcomes with different devices, the same outcome with or without perfusing the hepatic artery. And that is something we debated a long time, for many years, and everyone who transplants livers knows that the biliary tree is also perfused through the portal vein. There's branches, there's anatomy papers, and we stained it with fluorescence, so the whole common bile duct is delivers oxygen through the portal vein too. The problem is in vivo, the oxygen value is too low. So in the HOPE, we have a very high oxygenation, and that's the reason why we protect the biliary tree even by perfusing through the portal vein alone, which makes it easier, particularly for partial grafts, for living donors, for splits, and for other scenarios where you may want to reconstruct the artery while you perfuse already to cut down cold storage. And interesting is this paper from Germany showing that with this high extended DBD risk, you see they have a DRI, the European DRI of more than 2, so it's more in the range of what we see in India. You achieve with single HOPE, portal vein only versus dual with the artery, you achieve comparable outcomes, certainly a comparable graft survival, same biliary complications, and other hospital stay and so on. So this is the first evidence, early evidence, and more will come on that. Overall, we have a lot of meta-analysis clinically. I'm not going to go into details, but this is a good one from Tingle et al. In the Cochrane library published. And in the end, it's pinned down to the key elements of outcome assessment. So we have a better graft survival, we have less serious adverse events, and we have less biliary complications, in particular less clinical relevant biliary complications, which is very important for countries like here in Asia, who think about implementing a DCD program, and you need a safety net, and we'll talk about variability assessment in a bit, but you need a technique that improves the organ and ensures that you don't need a retransplant, which you don't have. Among those presented meta-analysis, there's also analysis like this one, considering only the randomized trials. Alessandro did that, and you can see that this was a comparison separately for HOPE versus cold storage and NMP versus cold storage, and the overall result was that both reduce early allograft dysfunction in these randomized controlled trials, but HOPE has more effect and impact on those clinical relevant outcomes, which is very important. And I'm sure many of you have seen that recent paper published in Liver Transplantation this year, a network analysis, meta-analysis comparing NMP and also HOPE, and you see in top, it's a little bit highlighted that HOPE improves or reduces graft failure and also biliary complications in this study. Now, interesting is, and that is what happens everywhere in the world when you start a new technique, initially you want to be safe, and the same happens now in the pediatric field, and the same happened in Europe, and the same happened also in the US. Initially you want to be safe, and then you see, okay, it works, so I want to expand my criteria. And you see that on this slide. Until 2015, we just started in Switzerland, and then slowly other countries started as well and expanded the criteria. Now we have HOPE in routine use and even commissioned in a couple of European countries like Switzerland, in the Netherlands, for example, in Italy as well, for DCDs, for extended criteria, DBDs, and this is happening on a certain level in every country. If we look at the preliminary data of this randomized trial done with the VitaSmart in the US, we see again, at the other side of the ocean, we see similar results. We have a mixed cohort from 15 American centers, so DBD, DCDs, equally distributed among the two cohorts, cold storage versus portal vein, HOPE alone, and you see that you have a significant reduction of biliary complications. Of course, you also have an impact on EAD and hospital stay. And interesting is what others described, you also reduce immune response complications. So you have significantly reduced severe rejections and also steroid-resistant rejections, and we've seen that before in other studies in Europe. So cold oxygenation before transplant reduces this inflammation we see, we call reperfusion injury we see, and that is going through mitochondria, and you can see here, this was an experimental study on top where we saw that in kidneys and livers that hypothermic oxygenation after cold storage reduces the rejection. That was an allogenic model, and below you see our meta-analysis summarizing the literature for hypothermic perfusion with a reduction of rejection and related issues. And this is a recent paper from Alberto Sanchez and the team from King's College. They took all the livers in the randomized trials, the DBD and the DCD trial published before, and analyzed the rejection rates and the immune system, the response, and they saw that with HOPE you have 7% versus 46% in the cold storage arm, and that's because you have less innate immune response with more Treg cells and less cytotoxic CD8 positive cells when you do hypothermic oxygenation. So this is very relevant also for allogenic models and for ABO incompatible systems, even for living donors, for children, is very important. This effect is relevant. And the xenotransplantation field has realized that, and this is a recent paper showing that hypothermic oxygenation in kidneys reduce the injury in the same way as we saw it in a xeno model with a much better survival and normal function more than 14 days after xenotransplantation. So I think to successfully do that and establish this technique, if we want that, it will be perfusion as well. So a few slides on mechanism, just shortly to come to the viability assessment. Of course, we know mitochondria are the key why transplantation works, because these subcellular compounds can recover from the injury, and they have to metabolize these bad boys like succinate, and whatever happens in the donor's life, because the metabolic impairment comes with the donor and with the organ, even before you perfuse, and this all goes through mitochondria. And we have measured that many years ago, and we see that with hypothermic oxygenation, you reperfuse cold, you have a slower metabolism, and that's a benefit, because you can get rid of succinate, you can recover ATP before getting warm, so without this injury, without these bursts, and you have less reperfusion injury, less radicals, and less overall inflammation. And we compared that, because in the US, we are not allowed to use HOPE clinically, routinely, but we get a lot of discarded livers, so we can compare that. Human livers, warm and cold perfusion. And you can see clearly that you have less injury with the cold, even if you perfuse very long, and you have a better mitochondria function. It is complex 1 catalytic competency is there in that graph next to the Western blot, and you can see that you definitely have better function and less injury in these organs. You can stain it, you can assess it further. And this triggers all these downstream inflammation. And that's very relevant also for patients with cancer, because we transplant those risky human livers with fat and DCD livers in cancer recipients. And the mechanism is reported since many, many years. So we know that more reperfusion injury makes more inflammation and less regeneration, so small livers can regrow less well, and you have more cancer recurrence, particularly in this inflamed microenvironment in the organs and even in the lungs after liver transplantation. So this is a study already 4 or 5 years old now, where we showed that hypothermic oxygenation reduces this cancer recurrence. That was only a matched retrospective analysis. At the moment, there are now 3 randomized trials ongoing in Europe. And we need more, we need to compare the techniques, but HOPE seems to be protective, and this makes absolute sense from the mechanism point of view. Another key question, of course, we want to keep our team happy. The anesthetists want to be happy, and they are more happy if they can rest in between the cases, and if you have flexibility to do other surgeries, depends on the center where you are, but there's increasing evidence for HOPE being effective not only after cold storage and transport, but also for a longer time. So there's reports, you see that up to 12, 14, 20 hours, and there's also now combined multi-center studies from Europe showing that when you perfuse longer is actually beneficial. You can see that here, this is a summary of the current data, but you can also see that on the next slide, which is the study from Italy, where you see that more than 4 hours HOPE is actually good and shows similar effects with draining cytokines, metabolizing succinate, and protecting, for example, the kidneys from acute kidney injury, which is often seen in higher risk DCDs. All these benefits and all these reports from Europe have led other countries implement this technique. Not only India we saw, and you see the typical Indian liver there. It's not so big as the American liver, but it's already steatotic, and it benefits from perfusion and assessment. It's also an easy technique. You can easily combine it. You can put it even in a bucket, and on the left side is a system from Chile doing the hypothermic perfusion with ECMO. A similar system I learned today is used currently in Russia, but they also do the same out of their situation, use the ECMO system for HOPE. Now, overall, there's a lot that happened in the last decade, and you see that there's many countries doing it, many countries interested in doing it, and have done it now already more than many thousand times. Viability assessment is a key, though, and I always say the same for me and also for my colleagues in Cleveland at the moment. We measure viability every day, and a reliable marker needs to be related to where the injury happens. So it needs to come from mitochondria or wherever the injury happens, and ideally it's complex 1 and 2 where the initial reperfusion injury is triggered. And then it needs to be fast and easy and should work in every technique and should help me with my costs. And of course we want clear guidelines, because we as a team always discuss in the morning what we're doing, but it needs to be fairly clear. And the viability at the moment, based on the consensus meeting last year, said, yeah, there are some studies on this mitochondrial marker, FMN, NADH. You can see a summary here. There's some tested lactate, AST, the usual parameters we also measured during NMP. And to summarize that, the only marker that was validated in a multi-center study is for now the FMN, and we have recently published the methodology, was refined, and if you run, for example, a standard like an ELISA simple, you can always measure the FMN with any spectrometer. You can see it here, you can just change the gain. Many devices have a different setting, but the principle is the same, and it correlates very well if you know how to measure it for now. Sensors are developed at the moment, so I think in the future we'll hopefully have something more routinely usable for everywhere, even where you don't have the spectrometer right away, and even in the donor maybe up front. FMN is coming from complex 1 and has been tested many years ago, and if you look at the literature, you'll see even early papers from Japan and of course from the US in other settings like reperfusion injury, stroke, myocardial infarction. It has been shown to be released from those mitochondria in every cell. We have implemented it in the cold perfusion many years ago and published different series. You see that here, including the validation, as it correlates very well with graft loss, biliary complications after transplantation. And here you see that it's not a simple on-off marker, say, okay, it's a PNF or not. You can see that with increasing FMN in the perfusate, you will have more complications, more kidney, dialysis, cholangiopathy, and also graft loss as it evolves. And this was all validated with mass spectrometry, of course. Interesting is this. If you look at these two groups of HOPE livers, you have on the left side livers with short cold storage, and on the right side you have livers with up to 20 hours, 24 hours cold storage. In both groups, you have metabolically unfavorable livers. So whatever your static parameter is, it can look good, but in real it isn't. So only a biomarker which is reliable can show you that. So let's say you would like to split one of these livers on the left, which have a lot of injury. You need to assess that, and you cannot see it based on the donor parameters. And the same is on the right side. You have sometimes long cold ischemia and then long perfusion, but the liver is beautiful, fine, although you wouldn't expect that. And for me, it's always important to see that others find the same in their cohort, as you see here with a paper from Austria from end of last year. They measured in their HOPE cases the same biomarker and showed that it's correlating not only with EAD, but also with outcomes in the patient. So the last slide is linking to the next presentation, very important. If we want to expand the risk, we need assessment also, for example, in splits, and we have established this pathway. Rebecca presented it in the morning, that you can get the liver there. Even if you think it is not viable, you perfuse it, you assess, then you can decide, not only based on your historical criteria, but also based on the assessment, to go for the split and to consider it, to transplant it even in a child with more experience in the future. And you can either split during HOPE or after, when the right lobe has a long ischemia. So I was always a bit afraid when it's getting beyond 10 hours, and then you have a small vessel, a smaller artery, so the combined injury is risky, and this is helping definitely, and Rebecca will talk much more about that, but it helps with the logistics and it helps improving outcomes. My last slide is on costs, because that's highly relevant. And the data are scarce, and you see this is everything that's published today, NMP and HOPE NMP from the two main contributors, and you see everything in red is based on the systematic review missing. So these are all cost contributors, and of course we report consumable prices, device acquisition, but we do not consider personnel staff costs, for example. This is only presented by one of the trials with HOPE for now. So a lot is missing, and we need to do a better job and to assess it in different countries, of course, in different healthcare environments. This is the only cost paper for now that shows the cost efficiency, not only neutrality. So this is from DCDs, from the randomized trial from Groningen. Based on their randomized trial, you see that you get cost-effective if you do 30 human liver transplants with DCDs in their setting based on reduction of complications, and they include all the cost contributors in their publication. So that leads me already to the summary. HOPE for now is increasingly implemented. Of course, it is effective in all graft types and after cold ischemia, protecting from complications due to a reduced mitochondrial reperfusion injury. We can use it for prolonged preservation. Of course, we do that. We have to do that. We are currently further validating viability parameters, FMN and others, and it seems to be cost efficient, but we need more data. And we need, of course, more devices, new devices with integrated viability assessment in the future and more cost analysis. Many of my colleagues and collaborators are here, and I want to thank everyone in the team and everyone who is pushing together with us forward to learn more, to understand more, and I would like to thank you for your attention. Thank you.
Thank you, Andrea. I think we'll go ahead to the next talk and perhaps take the questions all together later.
Thank you. So thank you very much for the invitation, and I'm going to talk about expanding applications of hypothermic perfusion in liver transplantation. As we know, the donor viability is the main limiting factor, not only in the adult setting, but as well in the pediatric field. We know that there is an increase in living donation, but still 2/3 of the pediatric liver transplant procedures comes from deceased donors worldwide. And we know that there has been reports about the use of DCD donors in very selected cases with short warm ischemia time in the pediatric setting with good outcomes, but it still is very infrequent. But what is happening in the UK, and I think is happening in the rest of the world, is that there is a clearly increase in the percentage of the DCD donation, and we need to adapt as a pediatric and adult liver transplant surgeons to the new situation, and we need to improve the utilization and the results on that. And if you look to the other graphic, you can see there is at least 36% of donors from the DCD that they are less than 40 years old. When we do a split graft, we use the best quality livers. Why? Because we know that those livers will have a prolonged cold ischemia time that is associated with early graft dysfunction and loss. There is a major risk of post-reperfusion bleed on the cut surfaces, and we have an ischemia reperfusion injury. But we know that with the new technologies as hypothermia machine perfusion, there are reports, trials that we have listened on the previous talk by Andrea, showing that there is a reduced rate of post-reperfusion syndrome, better histological ischemia reperfusion injury, and improved post-liver transplant outcomes. And in this split setting, another advantage it will be that if you will reduce the rewarming because of the graft mobilization and the heat exposure if you are using a transection device, if you are doing a split. There are little reports in the literature, and the beginning were mostly case reports. The first one was in 2018, where they used a full graft from a pediatric donor, and they put it on D-Hope and transplanted a 16 years old pediatric. That was the first report of a DCD D-Hope utilization in the pediatric setting. After that, in Italy, they use the D-Hope to do the first split liver transplantation and being able to accept a liver from another country with long cold ischemia time to do a split and a further hyper reduction of the segment 2 for a newborn baby, and to use the right lobe for another pediatric in the same unit. After that, a year later, there was the first report using a D-Hope machine for a split procedure that allowed to do a pediatric and an adult from a different center, and both of them did very well. In August 2021, Maybrot et al., they reported the first case of single hope oxygenation split. They describe the two-step technique where they actually dissect the hilar plate and the structures, they divide the artery, then they connect it, they flip over the liver, and they do the transaction, all with the portal perfusion. Same group decided as well to show the feasibility and versatile use, and to do the first full left, full right split, and use and while the right lobe was in the machine, they actually reconstructed segment 8 vein for the outflow. And another use that you can have in extended right lobes is, like in this case, where they precondition and pre-transplant a DVD from a 6 years old, where the segment 2-3 went for a unit, and the other unit who accepted the right lobe, they declined it because of a size match. So this unit decided to accept it after 13 hours of cold ischemia time, and they put it on HOPE during 3 hours, single, and got transplanted with very good results. But of course, this is all case reports. So the first actually series from the French unit came with a pilot study to try to show if the split on HOPE was safe and feasible to do. For that, they collected the data from the split performed from 2020 to 2021, and they compare it with the 2 years before HOPE was introduced. They used the same technique, the two-step technique that I explained before, and what they saw were 3 observations. They actually saw that there was a significant difference in the cold ischemia time in the pre-HOPE era. Then they actually saw that single HOPE was easy and feasible, and there was no need or clinical data reported to suggest that the HOPE had better results, and for that will be clearly in your advantage the less manipulation of the artery. And then there was no difference in the postoperative outcomes, which support the use and safe use of HOPE during the split. And an histological finding is that what they found is less lobular neutrophilic infiltrate in the HOPE split livers, with less ischemia reperfusion injury in the post-reperfusion biopsies. After that, the same group, 2 years later, decided actually not only to describe the safety and feasibility, but compare it to the living donor liver transplantation. So they actually compare the cold storage pre-HOPE, HOPE, and living donors. And of course, what they found is that the graft preservation, the cold ischemia time, was clearly much lower in the living donor group. Looking at the reperfusion, what they found in the histological biopsies is that the ischemia reperfusion injury grade was significantly lower than in the cold storage, but there was no significant difference with the living donor liver transplant group. And what they found is that the post-reperfusion syndrome was, again, significantly different, with less need for noradrenaline or vasoactive drugs after the reperfusion of the graft in the HOPE group compared with the cold storage. And there was no difference if you compare the HOPE group with the living donor. They saw when they reported no difference in percentage of laparotomies, arterial biliary complications, and overall graft and patient survival. There is an ongoing multicentric descriptive study. This was started from the group of La Paz in Madrid, in Spain, and we are collecting data from 5 different centers, 2 in Spain, 2 in France, and one from the UK. So far, there are 56 cases reported, but it's still early days, so we cannot really extrapolate or come to very much conclusions because we still need to complete the data. But it's coming, and it's good that we really want to collaborate and not only present single series or single centers outcomes. I'm going to just talk a little bit about what we have done in Birmingham so far. So we started last year. Last year was our first case. And our first case was a DCD. So we used a DCD from a 6-year-old donor with a super rapid technique. And we used it in a 3-month baby that was waiting for some time because, of course, when you have a small baby, the size match is much difficult more with our current donation system. As in the children's, they were not, we couldn't use the machine because it was not approved. This split had to be done in the adult side, that is like 5 kilometers from the children's. So we had to go to the adult side, do the split, leave the liver running, go back to the children's, do the hepatectomy, and tell them 40 minutes before to disconnect the liver and send it to us. The child went very well, and he actually went home within 2 weeks. So it was a nice first case. Another scenario that we found useful to do a split is we had at the same time in the children and in the adult a child awaiting a liver transplant for hepatoblastoma and a paracetamol overdose adult. We had this very good offer from a DBD, and with good communication between both centers, we decided to do a split on HOPE, and we used the segment 2-3 for the hepatoblastoma kit and the extended right lobe for the paracetamol overdose, and those cases went very well as well. And the third scenario where we started using HOPE, either for full graft or reduced graft, like for example this case, is when we were expecting a long cold ischemia time and a hard hepatectomy, because the last thing or one thing that you want to not worry about is the cold ischemia time where you are doing a complex case. So in this case, we use a reduced liver on HOPE for a 5-year-old kid that had recessive polycystic liver and kidney and hepatic fibrosis with multiple previous peritonitis and long-term peritoneal dialysis. So the hepatectomy was a very challenging, and the actually reduced liver stayed on HOPE for almost 8 hours. Unfortunately, this child died 2 months post-transplant from sepsis, but the graft was functioning. Another logistics is, like in this case, we use a full graft, we put it on HOPE to try to focus on get a good arterial inflow for this kid, 13 years old, that was going to have his third retransplant. He had biliary atresia as a child, got a first graft with a supraceliac conduit, got thrombose, got a living donor from the dad, infrarenal conduit, thrombose. And then the third graft came from, we use a full graft, and so far the kid is anticoagulated and doing well. And the last case that I wanted to point out is one of the last cases that we did that was an unresectable embryonic sarcoma. This poor girl bled, and the intrahepatic bleed fully compress the hepatic veins, and she developed an outflow obstruction, acute liver failure. So we have to list her as a super urgent. We were pretty worried about this hepatectomy, so we wanted to forget, about the cold ischemia time and put the liver on hope, and with the help of the cardiothoracics, because we had to open the chest to get access to the top cava, we were able to perform a transplant and went pretty well, the post-reperfusion moment. So, as you can see, our median preservation time is longer as well than reported, because usually it report cases between 2 hours, 3 hours, 100 minutes, and we are close to 3 hours. Our results, we know that this is you take it with a pinch of salt, because we just started a year ago. So we have had one case of HAT. This was a 2 years liver that we went to retrieve from abroad. And this kid developed HAT, then the explant showed vasculitis in the liver, and got retransplanted, and so far is doing okay. We had one case of a bile leak. This was from a propionic acidemia child that unfortunately died, secondary to his metabolic crisis, because these children are pretty difficult to manage. So far, we have had no anastomotic stricture, no non-anastomotic stricture, and a curious thing is, so far, we have had not acute rejection, and we have compared to the previous 2 years, where we had a 14% of acute rejection, early acute rejection. So what I wanted to show is how not only you can use HOPE in pediatrics to perform the split, but it can be used to try to do more complex cases and not to be so focused on the cold ischemia time, because we know that matters for the outcome of the child, because we want the best survival and the best livers for them. And then, as the future of HOPE, well, we know that hypothermia has changed the adult liver transplant. We are seeing that can be safely and versatile use in pediatric transplantation. So is there a role for hypothermia perfusion in the setting of the living transplant? Well, sometimes, and please acknowledge that my knowledge in living donor is limited compared with all of you, okay? So sometimes you may get an unexpected long cold ischemia time, or maybe you have complex recipient, or maybe, as Andrea was suggesting yesterday, you have a teaching case, so you don't want to be worried of a longer cold ischemia time, so maybe you can put the living donor graft in HOPE while you finish the hepatectomy, or you reconstruct the outflow if you need. Well, sometimes we know that the size match of the EGWR is important, is very important, and sometimes we have big children with a left lobe or an adult with borderline size match, and with the results that they have been showing, there might be a room for that. Monosegment, where there is clearly has been reported of a hyperreduction already from Italy. So you can use the segment 2, 3 from a living donor, put it on HOPE, and do a further reduction. We have data that suggests that there is lower rejection rate, so maybe we can improve the rejection rates that you have in living donation. The problem with well, not a problem, but we know that the selection criteria, of course, is very strict to try to be very safe into the donor side. So if we are able to oxygenate and to get better results with less ischemia reperfusion that we have seen already for fatty liver grafts in hypothermia, maybe you can increase the pool of potential candidates. And we have been talking, or sorry, Andrea has been talking about the incidence of less cancer recurrence and the ongoing trials. So maybe there is a room as well to try to do even a rapid technique using liver being perfused on HOPE. I want to thank you very much, all the teams in the Children's, the teams in Birmingham, and of course all my colleagues and fellows that I work with. Thank you very much.
Thank you so much. Those are two fascinating talks because on the one hand, we are talking about increasing viability for a longer period of time, reconditioning livers, but we also have some evidence that there is some immune modulation that happens as well, because obviously the HCC recurrence rates come down and perhaps the rejection is lower. So Andrea, I mean, just sort of dialing back a little bit, right now we have two distinct methods of machine perfusion. We have hypothermic and we have normothermic. So broadly speaking, can you sort of define use cases where hypothermic, one may be better than the other in your thought process?
I hope that works. Yeah. Yeah, that's a good question. And we will go into that scenario in the US soon as the FDA approves it. And my team says the same, what do we do, how, and when. So, I mean, both techniques have a place. I just think you have much less inflammation with HOPE. So what we see sometimes when you keep livers longer on normothermic, you get, of course, a reperfusion injury. You get your correlate in the tissue. You can see that on necrosis biopsy when you go towards 20 and more hours, even in good livers. And you don't see that in HOPE, even with long perfusion. There's a nice poster outside on senescence, for example, where you see that HOPE reduces inflammation and protects mitochondria even from senescence, which happens often under normothermic conditions. So I think there's a lot of benefit. Of course, centers who are now used to NMP need to learn that they can trust HOPE, they can trust the viability assessment, and we all need to learn that. And because every country has this huge donor pool, which we can use, not only India, everywhere. Yeah. But we want the reliability, we want the robust, and we want to be safe. And this is a process. So if you ask me today, what's the role, I would probably perfuse every DCD liver cold, at least, and assess it in the cold, because I think DCD livers should not be transplanted without any perfusion. Agreed. I also think steatotic livers for sure should be perfused, if you can cold. The EFOT system shows us that if you do anything warm, you should do it right away. It's not working so well after cold storage, which is the mechanism and shown by many, and we see that. So warm perfusion after cold storage only with viability assessment, with real assessment, not only bile flow or lactate, that doesn't work enough. We had 3 PNFs with that, despite that, historically, not anymore. But that's the thing, you can do it, but you need to test it. Sure. And costs, of course, are relevant in the system you are. And I mean, sure. I'm not knowing you've seen logistic challenges.
No, I mean, I was going to come to that because so we have a pretty wide area to cover when we talk about Southeast Asia. We have Korea and Singapore, which are pretty comparable to anywhere else in the world. And then, of course, there are countries like India and Nepal, which have wide variation in socio-economic affordability. So I think that, of course, you can't have one size fits all. But coming back to viability now, that's been one of the bugbears for hypothermic perfusion because FNM, although we've heard about it and there's been some very good data out of it, having a robust, easily implementable system by which you check viability, are we there yet, or do we have some way to go?
I mean, it took a while to publish that mechanistical paper, which is now showing how to measure it in in cold, in warm, in NRP, in donor blood even. So you can, FMN is not something I identified. It was out there, measured by many. So you can easily measure it in everything, in flush solution, in anything. The good thing is when we have more data on consistent methodology of the perfusion, let's say we do HOPE always with the same machine, with the same solution, we do NMP with the same solution, with the same amount of fluid which recirculates, we will get enough data to support our threshold, to say, okay, I have this system, I have this temperature, I have this threshold, I can follow it, because that's the problem. Everyone has a little bit of observed something and has some different technologies. And when we have that, we can rely on it. And in HOPE, we have that. So we see identical behavior of livers. When you do HOPE, you have a threshold and you fail the threshold, and you rewarm, you fail the NMP threshold. So we can really rely on that metric for now. The problem is, in the warm for now, that if you perfuse longer than, let's say, 16 hours, the initial assessment in the 4 hours needs a repeat measurement. So you can, of course, not say, okay, in 2 days, the liver will still be good. If things change, organs don't want to be outside for so long under warm conditions, so you need to remeasure. We're doing that now and get more and more cases. But I think FMN is probably not the end. It's just a good start. And the sensor, the question if we will get the technology, I think we're developing the technology, companies develop the technology, and future machines should have that, at least to be able to, I don't know, combine it, to have the technology. Everyone measures the leaves out there with vitamin B2. They measure it in nutrition, testing food. It's not rocket science. So we should have it. We should implement it.
Sure, for sure. For Rebecca, my question to you was this, that now you've talked about DCD and the split work, but there's another use case that you have where you have anticipated difficult explant. So will there be certain situations where you had a DBD donor where you were anticipating a difficult explant and you would still consider putting an organ on a machine?
Yes. We actually, right now, we are in a place where we believe that we will use HOPE as a standard of care.
Okay, that is for DBD as well?
Yeah.
Yeah, that's a big change, isn't it? And when you actually do a split, then would you still stick with the same GRWR methods that we use for living donor, or would there be any differences?
Well, usually there are differences because you don't have that limitation that you have in the living donors.
Right.
So it's usually easier and you have a higher.
Okay, so you would get a little bit more volume, so to speak.
Yes, but you can easily use as well a borderline size match. Sure. So it's described, one of their reports actually use it, and they have a short period of a small force size that actually recover like in 48 hours.
That's quite interesting. Now, again, the challenge, of course, is that DBD is currently increasing in Asia, and certainly even countries that have had very robust living donor programs like Korea and even Singapore now are seeing a robust increase in DBD donation. DCD donation is a little sort of slow to pick up. India passed this law 2 years ago, and we've just seen a handful of withdrawal of life-sustaining cares happen so far. So certainly these things will take time to pick up in this part of the world. So now the challenge before us is to define a group of patients from DBD donors who could potentially benefit from this technology. Right. So is there any evidence, because you've presented a ton of evidence on DCD, if we go back into that, is there any evidence that would perhaps translate into use for DBD donors in this part of the world? Sorry, tough one.
No, I mean, if you look at the randomized trials, for example, most randomized trials included DBDs. Yes, extended criteria DBDs for age, steatosis. The Germans have very extended donor risk, and there's a good evidence for DBDs. Okay. So the answer is yes, DBD for sure. The question is maybe the most beautiful DBD, does it need to be perfused? Okay. If you have a challenging recipient, I would say yes. I would do it because we see this immune effect as well. The effect on cancer will be confirmed soon. So I think in the end, once this technology is affordable for everyone, we should probably perfuse every liver, even a good DBD, for the recipient. For medically risky recipients, not MELT, but cardiovascular risk, posterior perfusion syndrome risk, all those cases, yes, for sure, because you not only improve the energy of the organ, you also have less potassium coming out of it because you have more energy, sodium-potassium pump works better. All these effects we see are, of course, important in these patients too.
I mean, the immunomodulation is a really good point, and perhaps we're learning more about this now. Dr. Isaac.
Yeah, thanks, Sonal. Well, thank you both for two brilliant presentations. But Sonal, as you said, there is a need in this part of the world for DCD, but there are issues. So I'd like to ask Andrea, really, if you were advising a department on how to progress a DCD program with regard to NRP and or HOPE, how would you frame that? What would your advice be in terms of getting the program started?
Yeah, that's a good question. NRP is, of course, good upfront. You have time even to allocate a liver, which is on or perfusing at the moment. What we see when we look at the data from Europe is that NRP works well up to a certain injury. The same is in the US. We are not there yet with the injury, but if you look at data from France, for example, when they go beyond 30 minutes functional warm ischemia time plus 5-6 hours cold storage, you get your complications because you have crossed a certain injury. Of course, it's hard to predict with lactate and transaminases, so we need better viability assessment on the NRP side. We'll hear a little bit about that tomorrow, but that's one thing. NRP works to a certain injury. Same like HOPE. HOPE works up to a certain injury after cold storage. If you have the option to measure, it's good. I think the Italians do a good example because they combine it. They have, of course, this very long standoff period of 20 minutes, so they have a lot of injury despite, I always say, red wine and olive oil, so they have definitely not so much steatosis probably and other risk, but they have long warm ischemia. And also long cold ischemia in between NRP and HOPE. So if I advise a program, particularly in a country where you have maybe not so many options for, if you have a PNF, you have node, you need some viability assessment. Because even we had a case recently, even in Cleveland, beautiful DBD and a DCD donor, young, 20 minutes, functional, NRP perfect, 5 hours cold storage, did not work on NMP. It was terrible metabolically, and you did not see that. Not traditional markers, not during NRP, you did not see that. So that's why NRP is good, but without additional perfusion or any assessment, I would be careful.
Yes, sir.
Hi, Chase, Cleveland Clinic. So I'm with you, Dr. Schlegel, but with represented on the panel are three perspectives from around the world with different transplant systems, and now there's NMP, there's HOPE, there's NRP, there's ischemia-free, there's new viability markers. So I guess taking one step back, where is this going to go in 5 and 10 years in the respective transplant systems? Because there's different donor availability, there's different organs available, there's different moving parts literally and figuratively. So I guess I'm curious everybody's opinion on where we're going to end up in 5 and 10 years as a system, not just looking at a specific per liver basis.
Is that
For everyone, all three.
Okay. Okay. All right. So I think that you're absolutely right. The one thing that's standard across the world is perhaps the requirement for transplantation. How we get there is going to be very different, and healthcare, especially my next question was going to be funding, so is going to be differently structured because it depends on the culture of the country and the history. Actually, there are many things that go into that. But broadly speaking, I don't see these things as exclusive things. I think I see these things evolving parallelly into different systems, and as we evolve, we will find out use cases where one is better than the other. And there will be certainly cases, for example, where perhaps there is a robust DCD program, like Spain led the way in, and certain parts of the UK led the way in NRP. I think there will be certain centers of excellence that prefer one over the other. And I do see this continuing as systems that are evolving in parallel with certain centers of excellence, which will be based on essentially donor availability in that particular area.
Yeah, that's a good question, Chase. I think we will have perfusion more and more. Many countries will implement it as it fits into their environment, healthcare costs and everything, logistics. Of course, techniques which are easy and, yes, effective, but easy and cost-effective will have an easier path to be used. Not even talking about regulations, we have challenges in different countries, but I think if I advise a country has nothing and I say, look, you want something easy, start with the hope, it's easy, reliable, and you can take it from there. I still think we need the warm techniques maybe for research too, to explore new treatments, to assess what we want to do in the future. So, but clinically, I'm pretty sure in 5 years we will be here and we will look at a, I don't know, fully colored world map almost. Every country that does transplant will do some perfusion.
Yeah, there'll be different colors though.
Yes, and I think the costs will be a big driver, and we need better data there. We need to report outcomes uniformly to get more comparison to answer that question in more detail.
I agree. I mean, I will ask a GPT chat, but I don't have the phone here. So I think probably evolution will happen in different countries in different ways. I think having the different access to different technologies is always good, and you can always learn from everything. We have learned as well that NRP, for me, for example, for UK is very important, but we cannot have NRP in every donor, so we don't have that availability assessments either. So you need to play or to try to utilize in the most effective way what you have to try to get the best results. And I think we are every time getting better at that, and probably we will continue to improve in 5-10 years.
I got a question for Dr. Schlegel. And first of all, congrats for all talks. They were great. My question is if there is good correlation of FMN with electron microscopy findings or mitochondrial function, if there is a clear correlation. And the other question is if you need to correct FMN for graft weight, for example, or other factors.
Yeah, thank you. This is, of course, very interesting. We assess now all these normothermic livers we discarded on pump and the hypothermic ones for tissue markers. So you can definitely correlate FMN release with mitochondrial injury and function. You see, for example, that mitochondria work much better in the cold, more efficient. Complex 1 has a higher NADH turnover than under warm conditions. You can see high FMN releasing livers, so a lot of injury livers have high injury on complex 1 and 2 if you stain for it. You see a lot more senescence in those livers. You see no peribiliary gland regeneration. So high FMN means the peribiliary glands do not regenerate and the bile duct is too injured, you will get your biliary complications. So we have done that. We're about to publish that in warm and has been shown in the cold already. So HOPE, yes, and NMP is coming now. The correlation with graft weight, yes, it correlates. We have checked it. But if you have, of course, a cohort, let's say, of 100 livers, which are very close in the weight, like 1,900, 2,200 in that range, it makes not so much impact. But if you have a big range, like 1 kilo to 3 kilo, weight correction is, of course, relevant. As is fluid, whatever you recirculate on the machine has an impact, and we see that during NRP when we measure in the donor, and you measure FMN, and you give a lot of volume because you need to maintain your circuit, you will have some changes. But that's what I said earlier, if you have a standardized protocol how you perfuse, you can develop and follow the threshold in all the techniques.
Excuse me, thank you very much for very nice presentations. I have two small questions to Andreas Schlegel, if you allow. First one is mechanical question. According to prolonged hope, if we do it for 12 hours, for example, do we need to change the solution? Is there a need to do that in some point? And the second one, there is a lot of papers now about mitochondria transplantation. Do you think there is a benefit in it? And is there going to be some challenge in machine perfusion and mitochondria transplantation in the future?
Excellent questions. Number one, the perfusate. There is data in the heart for normothermic perfusion that you should change the perfusate after 15, 16 hours because it recirculates and communicates and activates the heart too much. So I think under a normothermic condition, there is some data that you benefit from that. In the cold, there's not much data. We see much less activation, much less release of injury molecules, so I have not seen the evidence for that, but we need to explore that further. The solution is a big topic, and we can talk a week about that, because we can add things. We should protect mitochondria. Mitochondria transplantation is very interesting. I'm also interested very much. I think challenges are or were historically that you need to isolate mitochondria right away from the same person or having them ready for big livers in a high quantity. I think now with FMN we have a marker that can identify livers that may benefit from a treatment. So we can now sort of say, okay, we have this on the machine now, let's treat.
Perfect.
But there's a few technical things that should be sorted. But I would try it. Try that, try organoids, try whatever we have in those livers we identify. So mitochondrial transplant is one option of those.
Sure. Thank you. I think we've run out of time, so we'll happily take some questions over coffee. Thank you so much for attending.